thousands are raving about our best-selling 100-patient scenario book. And so we started creating the expansion books to go along with it, including the cardiac arrest scenarios, we have the airway scenarios, pediatric scenarios, and the MCI scenarios. And you can get this entire bundle at the link in our bio. This is MasterMedics. MasterMedics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below. All right, good afternoon, everyone. Hopefully everyone's having a great Friday so far. Today we're going to be talking about crush injuries and kind of pertaining to the case that we talked about earlier this morning that was released, and if we need to apply tourniquets and those types of things. So it's a very interesting case, pretty high stress, pretty dynamic case, and lots of things to talk about. So let's kind of get right into it after we get everyone filed in here. So while we're waiting for everyone to kind of come in, let's take the next minute just to kind of let everyone know where we're watching from. Where in the world are you watching this live stream from? I always love to do this. So go ahead, throw that out, do a little shout out, and we're going to get started in a minute as soon as everyone gets a chance to pop in here and get settled in. Where are you all from? Let's see here. Where are you all from? There it goes. Perfect. Canada, the UK, Malaysia, Ohio. Whereabouts are you from? BC, Finland. Very cool. We state? Oh, Washington State. We. Let's see what's going on over here. Moncton, New Brunswick, Namibia, Edmonton, New Hampshire, South New Jersey, right on. All over the place right now. That's fantastic to see. I love seeing this. And so if this is the first time you've kind of seen us and kind of what we do, my name is Geoff. I'm with MasterMedics. I'm the owner and lead educator with them. And what we do is that we do live streams every Friday talking about a certain case and break it down. We do these 100% for free. We also do games for free on Wednesdays, and we also do internal stuff as well. We have our own learning management system for students that are struggling in school and paramedic and EMT school that want some help. We are the masters at that. That is what we do. We've helped over 30,000 EMT and paramedic students worldwide with their studies. And so if you're interested in that and you want to be a star student and stop struggling in school, you can certainly check that out on a 3-day free trial. So that's what we do. Okay, so let's get into this case here. Today we're going to be talking about crush injuries and how this particular case is quite challenging and kind of the whole aspects. We've already talked about that. So I just want to make sure I hit record so that way we got a good high definition one here as well. All right. So let's get into this case here. So you're dispatched to a male patient who was trapped by a cement pipe. Upon arrival, you see that he is conscious, alert, in significant pain and has both legs trapped under the pipe, as you can see here in this picture. The fire department suggests it will take 30 minutes to safely extricate this patient. He's already been pinned for roughly 9 minutes. Okay, so 9 minutes, about 30 minutes. So you're probably looking at somewhere around 40, 45, maybe up towards an hour trapped underneath the cement pipe. And this cement pipe would weigh probably a couple tons. So it's a very, very heavy pipe that has rolled onto your patient's legs. Looks like the pelvis is unobstructed, but it looks like both the right and the left leg are equally crushed. So that's our patient based on kind of what we're dealing with. So while the extrication is going on, we're going to get a set of vials. Here's your initial set of vials. Okay, so heart rate's 142, blood pressure is 137 on 85 with a MAP of 102. ETCO2 is 33 with a breathing rate of 28. SpO2 is 97%, and that is on the upper limbs, obviously. Okay, so based on what you see here, based on what you have, my first question to you is, why is this patient compensating so well? They've been crushed, both limbs are crushed underneath a massive weight. So we have a pretty significant injury that's gone on here. Why is this patient not crashing in front of us? Go ahead, throw that in the comments. Why is this patient compensating so well up until this point? What do you think? What do you think? Why is this patient doing so well right now? What are your thoughts on that? Any guesses? Let's see what you got here. The pipe is preventing excess blood loss. Blood circulation is stopped by the heavy object. Pressure kept under the extremities. Pressure from the pipe stopping hemorrhage. You guys are exactly right. So basically what's happening here, if we go back to our patient, is that the patient itself is crushed under this pipe. And so all of that circulation that's in the lower legs is compressed. Okay, so think of it like this, is the fact that this pipe right now is acting like a tourniquet in some aspects. And so it's not allowing any blood loss to occur because it's compressing those vessels. And so the pressure that we're getting, the heart rate that we're getting is basically all of that blood that's staying in the upper extremities, and it's staying there because we no longer have any access to the lower extremities. It's just being directed to the upper extremities. And so why do we have such good compensation right now? Well, the answer is, like you said, is that we have all of the circulation that's staying from here up, okay, from here up, which means that we're not really having any blood loss at this particular point. So as dangerous as this patient is, as high risk as this patient is, in this present situation, they're stable because they're not experiencing any blood loss right now. But we do have to get them out from underneath this pipe, and that is where the risks start to come up and where this patient's going to start to rapidly deteriorate on us. Okay, so that's what we have right now. Now, my question to you is that it's going to take the fire department 30 minutes to get this patient out. And once we get the patient out, you can expect that this amount of pressure that's been under these legs, you can expect the femurs and even the tibia and the fibula to be completely pulverized. Okay, that's kind of the pressure that you can expect. And so there's probably no rigid bone left in the lower extremities. It's going to be pretty much loose. It's going to be loose tissue underneath there. And so my question to you is is that should you apply a tourniquet after extrication? So what is your thoughts on this? Like, what would you do in this situation? Would you apply a tourniquet? Would you just put it there and then leave it to see if you have significant blood loss or any external bleeding? What's your thoughts on putting a mat or a tourniquet on this patient once they're extricated? Chelsea's thinking yes. Adrian's saying yes to manage compartment syndrome toxicity. There's no active bleeding. He's perfusing fine, but there's some. Okay, so that's from before. Sorry. So you're thinking yes so far over here. Let's see over here. Yes, apply the tourniquet. I would say yes to prevent blood loss. Once compression is released, patient will start to possibly crash. I totally think that's exactly what's going to happen here. Depending on how high the pipe is, you might not be able to. True, that is true. You might be limited on what you can actually get on them. Let's assume that there's some upper extremity that is intact. Okay, let's assume that some of that femur is intact just for this purposes, so that way we can kind of continue on with this this kind of discussion. Slow release of tourniquet to hospital. Okay, yes, prevent acidosis, hyperkalemia. Okay, so I think I know kind of where you're all going here with this. Let's come back here. Okay, so should you apply a tourniquet after extrication? Keel's thinking no, just prepare. I think yes, go ahead and head of the issue. I'm kind of in that realm as well, Autumn. And so here's what I would say, is that this patient has compromised circulation. So I'm going to glare, I can't quite see. There we go. Okay, they have compromised circulation right here. Okay, and below. And so when that is crushed, what do you think happens to these vessels? What happens to those vessels when you have a crush injury? Do they stay intact once we release that pressure? Or do you think that they effectively rupture and are damaged and we're having a lot of problems that way? They're ruptured. Yeah, I would agree with you, is that most of this tissue is compromised. It's damaged. So we're talking about just blood loss here. We're going to talk about the crush syndrome in a second here. But in this particular case, you probably have significant bleeding, not just from major vessels, but also like a bunch of different smaller vessels, all trying to clot and stop bleeding. So once you release this pressure, and all of these compromised vessels are going to start to bleed all at the same time. And so you have, even if you don't have any external bleeding, you might have some external bleeding, but even if you don't have any external bleeding, there is a significant amount of bleeding that's happening internally here. So pretty significant problems. One second, I just gotta sneeze. I'm sorry, pardon me. So you have a patient that probably has a lot of internal bleeding here that can't be stopped in other ways. And so using a tourniquet for that thought, if you have some room to do that, wouldn't be a terrible idea, is using a tourniquet in order to, to stop. So that's the first reason why I think a tourniquet is warranted. There's not a lot of evidence to suggest that that's going to help a ton, but the physiology makes sense. The thought process makes sense. It is that we want to keep the circulation in the upper extremities and the core as much as we possibly can. And one way that we can possibly do that is trying to collapse some of the circulation that's already compromised and keeping good blood up here. That's the first reason. The second reason that a tourniquet is likely warranted in this situation. Now, 1 hour is not really a long time, to be trapped and crushed from a crush syndrome perspective. And what that means is that when you have compromised circulation, you have compromised cells that effectively die. What happens is that if this is the cell wall and we have a significant amount of potassium on the inside of that cell wall, when you rupture a significant amount of cells, particularly the entire lower extremities, then this potassium is no longer encased in these cells. It is now going to end up in the circulation in the veins and in the arteries. And so what happens is that when you release the pressure of, say, this pipe, all of this potassium that's now collected inside, this is not just potassium, but other things as well, but all that potassium that's collected inside the blood is now going to return to the core, and this patient could be at risk for a significant rapid increase of potassium in their blood, which we know is going to create hyperkalemia, and this patient could go into arrest for that reason as well, among other reasons that they could too. So that is a concern. Now, does this happen in a very rapid fashion with crush syndrome? No, it's a little bit slower. So 1 hour is not a lot, but there is a risk for it. And so we're going to be risk adverse. And yes, potentially, again, tourniquet those vessels so that way this potassium can't return. I do believe that the tourniqueting of these limbs is more going to be important for blood loss and trying to keep the blood that we have still circulating in the body. I think that's more important in this particular situation. But again, same thing is that we could have this crush syndrome that could cause potential hyperkalemia. So I believe that if you are going to apply the tourniquet, there's a couple people that said, if we apply the tourniquet, should we also release it slowly? No. Once you apply a tourniquet, the tourniquet stays. It does not get released by you. This is something that they can manage in the hospital. Prolonged tourniquet application actually is quite well tolerated, and so you don't have to worry about loosening a tourniquet or anything along those lines. It's well tolerated, even for several hours. And so this patient will be just fine with 2 tourniquets in place on these limbs. Okay, so that's the first thing. Should we apply a tourniquet? I think that in this particular patient, it is absolutely warranted for the 2 reasons that we've discussed. So let's move on to another question. Is what other treatments should we prepare? So I guess to walk into this question is, what type of shock are they in? What type of shock are they actually in right now? They're compensating, that's fine. But what type of shock would you consider them in? Go ahead and throw that in the comments. What type of shock would this patient be in? Compensating. Yeah, they are compensating. Once you release that pressure, they would be probably decompensated. But what type of shock? Not what level, which is the compensating, decompensating, but what type? And you guys have got it, okay? So this patient is very likely, again, in a hypovolemic type of shock. So if they do go hypotensive and go decompensated, they would be going decompensated due to very likely a hypovolemic state where they have a low blood volume. And so knowing what type of shock that they're going to ultimately be succumbing to or going towards, what treatments, traditionally speaking, what treatments are going to be beneficial in helping this patient? Go ahead and put that in the comments. What treatments in hypovolemic shock, in traumatic hemorrhages, are beneficial for these patients? Go ahead. Fluids, saline, hypovolemic. Oh, we're still on that. Okay. I'll keep an eye on large bore IV and fluids. Fluids. Aiden's got something that I'm thinking. TXA. Same with Ben's thinking the same thing. Richie's thinking the same thing. And Autumn's thinking blood, and I totally agree with that as well. So, okay, so let's unpack this and think about kind of the treatments that should come into play when it comes to hypovolemic shock. Okay, so the ones that I have in place for the first 2. First off, this patient, do they require oxygen? Well, their saturations are at, 97% right now. I'd expect that to be dramatically reduced as this patient decompensates. And so I don't think there's any reason to be to not be proactive and apply oxygen to this patient. There's no reason why we can't give oxygen in this particular patient, even if their saturations are 97%. A trauma patient, why not? There's no dangers to that. When it comes to restricting oxygen, that's more towards strokes, heart attacks, those types of things that we could have an internal vasoconstriction issue. In this particular case, we're not really concerned for that. So oxygen is totally fine in this patient, even if they have an appropriate saturation. It's, in my mind, being proactive for how this patient might start to decompensate in the near future. So oxygen, absolutely. Second thing is that I would highly suggest is TXA. So TXA as early as possible. So while this patient is still being extricated, so while they're still trapped, I would suggest using TXA. So the reason being is that TXA has proven to be effective at the earliest possible time of insult. So if we prolong the administration of TXA from this time of incident, then it is less effective. And so ideally give TXA as early as possible in order to start helping with the clotting process and allowing for or keeping the body from breaking down already formed clots that are there. So I think TXA is a very good medication to be thinking about in this particular situation. Now, the fluids is only if you have hypolimic. So if you remove this cement and all of a sudden they're still compensating, their blood pressure is good, they're not losing any, you're not seeing a dramatic drop in their blood pressure, then maybe you don't need to give fluids in this particular case. So maybe we got lucky and we didn't have significantly compromised legs or circulation in the legs. But in this particular case, if the pressures go below 65 MAP, okay, a MAP of 65 or a systolic of 90, then using fluids in order to get your MAP above 65 or get your systolic above 90 is appropriate until we get to the hospital, or until you get the one thing that's really going to be beneficial for them in any type of traumatic blood loss is blood. And so the whole idea of fluid, of isotonic fluids, is literally to buy this patient time until they can get this, okay, and surgery, obviously. So that's what you're going to be really thinking about, is that, okay, I'm just going to give as much fluid as I need just to make sure that my MAP is above 65 or my systolic is above 90, whichever one your protocol says to do. And the whole point of that is to just give as much fluid, just as little fluid as you possibly can, until you can administer what's actually important, is replacing the blood volume that is inside, that we have lost, okay, because of damaged circulation into the lower extremities. And so that's really kind of what you're thinking as far as treatment goes. And so during extrication, thinking about giving TXA, putting them on oxygen, getting an IV, and then having fluids ready in order to maintain your blood pressure. But if you have a 30-minute window or even a 40-minute extrication window, and you have a patient that is high risk and high likelihood needing blood, it wouldn't be a bad idea to just think, I should probably get blood here or get someone to bring blood here, so that way we can administer it the second that we are on our way. So that way you're kind of thinking ahead and buying yourself time, and that way you're introducing what needs to be introduced, which is blood products in this case. And so someone's asking calcium gluconate. I'm okay with that thought process. Now, this probably won't fall into a lot of protocols, but calcium in itself, 50% of blood loss patients or hypovolemic shock due to traumatic blood loss, 50% of those patients are hypocalcemic or low calcium, sorry. And calcium has a big role in clotting. And so it has been talked a lot about lately to introduce calcium as a medication to give in traumatic blood loss. The efficacy of that is under debate right now, but the physiology of that makes a lot of sense. Is that if we have low calcium, then we're going to have a problem with clotting. So why wouldn't we give calcium in those patients? And so the efficacy is undetermined at this point, but I'm totally on board with the thought process of why that should work. Because yes, you're right, is that most of these patients have traumatic blood loss do also have a related hypocalcemia too. So good thought. Okay, another thought is Autumn saying be ready to intubate or RSI if you need to. I absolutely agree that it's not a bad idea in this particular patient as well. Now, keep in mind too is that this patient was screaming in pain. They were in immense amount of pain during this extrication process. And so what would be your go-to medication in order to help with this pain? Go ahead, put that in the comments. What's your go-to medication in this situation to help with that pain? What are your thoughts? An opioid, ketamine, morphine, ketamine, fentanyl. So yeah, I'm on the same board as you all. I mean, if I have the choice between ketamine or fentanyl, in this particular patient, I'm probably going to pick ketamine over the fentanyl. The reason being is that I have a patient that I know is going to deteriorate quite rapidly, and I need them conscious. I want them to still have a respiratory drive. And so I would imagine that you're probably going to use a significant amount of fentanyl or morphine in order to even touch this patient's pain. And so you risk the chances of them having a depressed respiratory drive and depressed compensating factors. So I do think that ketamine is probably a more appropriate choice in this case because of the adverse effects you could have with fentanyl and morphine, of being the respiratory drive, depression, and sedation, and those kind of things. So ketamine seems like probably the more appropriate pain control medication for this particular patient. I could be wrong, but that's probably the route that I would go in this. And I don't think that using something else is wrong, but you just have more risk of adverse effects. So that's a great thought. And I totally agree with Autumn is that intubation may be in this patient's future. I would almost be certain that they're going to be intubated at some point, whether it's with you in the air or at the hospital. They're going to be intubated at some point. So if you have indications that this patient does need to be intubated, I totally think that that is a thing that could be done earlier rather than later. For sure. Yeah, so that would be something that you have to really be thinking about of a possibility is needing to intubate this patient. Totally agree. As a PCP Entonox, during the extrication process, I really don't have a problem with this. Using Entonox in these particular cases, no contraindications. This is a musculoskeletal injury, technically. A very significant musculoskeletal injury. And Entonox can be a useful medication, this, especially if your hands are tied, that you don't have any opiate medications, you don't have ketamine, and you have this during that extrication process and they're still conscious and alert. I don't think Entonox is a bad choice at all. Totally agree. Perfect. So that is what we have for you today. Again, thank you for joining me. And if you want to learn more from us in this way, we do these through a continuing education portal as well. So if you want to get credits for these types of classes, we do these on a regular basis. We make them totally interactive and totally interesting, asking you questions, then giving you the answers to that, and making them all case-based. And so if you love the way that you teach, if you're in paramedic or EMT school, we have a learning management system for that. If you're a current EMT or paramedic, anywhere in the world, we are accredited in the United States. We're approved all over Canada. We're approved overseas for continuing education credits. And so if you want to learn more from us and get credit from us, you can certainly do that as well. On our dashboard, you can get access to our continuing education portal too. So thanks again for joining me today. I'm going to take a quick look, make sure we don't have any more questions. But that's it for me at the moment. And if you want to join or sign up to a trial, you certainly can do that in the link in our bios and check us out there. And if it intrigues you, please join us. And if it's not for you, that's totally fine as well. Keep enjoying the live that we do every single Friday, and we'll be happy for you to all show up. So let's see if you have any questions, and then we will come walking around here. No problem. I have members that are saying thank you already, and I appreciate that. Thanks for joining through the membership. What days do I normally go live? Typically, I go live on Friday afternoons, right this time. We're going to be going live on Wednesday evenings quite a bit because we do games nights on Wednesday evenings. And then We also do and then we do lives internally on Mondays, and we also do one-on-one tutoring as well internally as well. Do you help with EMT school? We do have an EMT side to our membership as well, and you can check it out on a free trial and see if it's something that's going to work for you. We'll definitely keep it up. Thanks for coming. You're very welcome. Would you do a paralytic and general anesthesia during intubation? I would probably, I don't think there's any reason why you couldn't. So if I was to use a paralytic, I would use rocuronium. So I don't have an issue with that. Oh, thank you very much. Thanks for joining us. Shara. I'm trying to say your name. I think I got everybody. All right, everyone, take care, and we'll see you next time. Would I consider sodium bicarbonate? Probably not. There's not a whole lot of evidence with this, but for sodium bicarbonate, I see your point is that you're worried about the hyperkalemia. So if you do have signs of hyperkalemia due to the crush syndrome, I got no issue with it in that particular case, but I wouldn't prophylactically give it. All right. Thanks, everyone. Talk soon.